they will give you the score, and so they can give you the score, and they will ask you the management. So these are the three streams of management. One is the community-based management. The second one is the ambulatory daycare management, which is an outpatient management. And the third one is the inpatient management, in which we have to keep the patient admitted. So, for the community, we all know that what is the system in the NHS. Patient usually report to the GP first, and GP takes the complete history, and he or she will decide the management plan for her. If she find any risk factor in the patient, and patient is having severe nausea and vomiting, so he or she will assess the signs and symptoms of dehydration, and it will be earlier consideration for the ambulatory treatment. And if the ambulatory treatment will not work for her, then the inpatient treatment will be given. Why inpatient treatment is at end? Inpatient treatment is a more vigorous treatment. And I think when I was teaching you the venous thromboembolism, what was the score for hyperemesis gravidorum? This is a very important question. You can just type in the chat what was the score of venous thromboembolism in hyperemesis gravidorum. Yes, please, audience, please do some mind storming and just answer me, because I've told everything in very detail, and I have given the scores even. So this inpatient, while I'm telling you, you have to write in the chat. So this inpatient treatment, I told you that whenever patient is routine, whenever we have admitted the patient, we have to do the venous thromboembolism scoring. VT is scoring at every aspect, at admission, during the stay, every day. Okay, and we have to calculate the requirement for Clexane or other antithrombotic treatments, or just hydration, or just mobilization. We have to decide the management plan. So whenever the patient is in or is admitted, we have to do the VT scoring. And if the patient is having hyperemesis gravidorum, the score is 3. Okay, and here we have to start with the Clexane. So we have to calculate, and this is the score just given to this condition. If we add the score with the other existing conditions, like the patient obesity, like smoking, the score will again go up, and we have to involve the hematologist, we have to calculate the exact dose for Clexane for this patient as well. Okay, so why we are doing this three streams of management, just to because we all know that the 90% will present to you. So it's a duty of a GP who will stratify the patient for you, and well, the most important is the ambulatory care. Why? Because here from ambulatory care we have to decide the plan for. We have to refer the patient back into the community if the symptoms are relieved, and if we find any comorbid or if we find any complication, we have to refer to the admission. Okay, so all three streams you should know very well. So these are the indications for the inpatient care. Inpatient care is uh, considered at least one of the following. So one, two, three, four, 4 points. We have at least one of the following. Then we have to do the inpatient. Continued nausea and vomiting, and inability to keep down oral antibiotics. Continued nausea and vomiting with clinical dehydration, and uh, greater than 5% of weight loss despite of oral antibiotics. And here you can see oral antibiotics are not been tolerated. Confirmed or suspected comorbidities such as UTI or other like other problems. Then other comorbids like epilepsy, diabetes, HIV, hypoadrenalism, or psychiatric disease. And here the patient is unable to maintain the oral hydration and medication. If woman is unable to tolerate oral antibiotics or oral fluid, then ambulatory daycare management. Okay. So in the ambulatory, what we are going to provide? We are just giving them IV fluids with B1 thiamine and parenteral antibiotics is preferred. Thiamine stored in a previously healthy individual can deplete rapidly and causes symptoms of tachycardia, weakness, and decreased tendon reflexes, which is within 1 week without intake. So ambulatory management in which we have to give the patient IV hydration and we have to stratify the patient into either back into the community or we have to give the inpatient. This is again the inpatient. So whenever the patient is admitted, ultrasound scan should be confirmed to see the viability, gestation age, multiple pregnancy, trophoblastic disease, and other medical condition that is where ultrasound is urgently required. So we all know that trophoblastic disease and multiple pregnancy can increase the risk of hyperemesis gravidorum. So what are the pharmacological therapies that are options available? So we can try the combination of different drugs which can be used either a single or delayed. In UK, the first line is the mostly doxylamine and pyridoxine with vitamin B6. It it were one of the like licensed drug which is most commonly used for mild to moderate cases. Then comes the if it won't work, then comes the parenteral or transdermal or rectal routes. If the oral regime is not working, then corticosteroids are usually reserved for those cases who are refractory to the treatment. So what are the antiemetics? So this is the line of antiemetics which you should memorize. In the first line, we have doxylamine and pyridoxine, and here you can see the dose is 20 by 20. So what are the preparations available over here in Pakistan as well? The dose is 10 by 10, and we can start with the 10 by 10 dose, and we can increase accordingly. Like we can give 10 at night and 10 in the morning. Then comes the cyclizine, it is 50 milligrams. Cyclizine is available in the market. I will not tell you the brand name. You have to search yourself, and you can even try 8 hours. Those who cannot tolerate this, because this is antihistamine and it has like some side effects of sedation, and those who can't tolerate it, we can try another one like prochlorperazine, promethazine. So these are all that can be given either orally, either intramuscular or intravenous. Prochlorperazine, it can be buccal and it can be given periphery as well. Then the second line. Second line have a more discussion. I memorized this second line as MOD, MOD, like metoclopramide, ondansetron, and domperidone. So these are the three important medications which are present in the second line. Metoclopramide is very important and is very effective, but it has some extra parameter side effects, and even it can be given subcutaneously as well, which is an extra advantage. Then domperidone, which can be given 10 milligram, and even it can be given parenterally. Ondansetron, 4 milligram, the dose is 8 hourly, or 8 milligram, the dose is 10 hourly. And for the IV, 8 milligram can be given over 15 minutes, 12 hourly, and 16 milligram daily per hectare. So these are the things that you need to memorize. One of the side effects with ondansetron is the constipation. For that, we need to give her laxatives as well. Then comes the third line, which is hydrocortisone, 100 mg twice daily given IV, and once clinically improved, then we have to convert to the prednisolone, 40 to 50 milligram per day, which is gradually tapered, and we have to maintain on the lowest possible dose. And what are the side effects if we are giving corticosteroid is that we all know that corticosteroids are associated with a disease in the blood sugar level. So we have to check the patient for the blood sugar level. And the second thing is that if the patient is keep on using this hydrocortisone during pregnancy, we have to give her what? We have to give her some medication during labor as well. So this is your homework. You have to tell me later on that if the patient is given either IV hydrocortisone or prednisolone, that what are the things that should be kept in mind and what should be given in the label, which is an important exam question as well. So antihistamines are the first line and should be prescribed earlier, and they should be combined with the other antiemetics at the hospital start. So once the patient is admitted, patient is treated, and now we're going to start. So we have to give them again with the antihistamine, and it can be combined with the other like dopamine agonist, antagonist, and serotonin antagonist. So this is about the again corticosteroids, and here we have to give the extreme precaution. And there is one important discussion. It's a very interesting discussion about ginger tea. We all know that there are some things that are usually like you have to take this thing to relieve your symptoms. So these are the home remedies, and there are some things that are present over the counter, and this thing is very common all over the world. So some things are some chewy gum, some like hot drinks. They are available over the counter, and that are usually decided that this thing is associated with nausea and vomiting. In the previous guideline, even they have told that ginger tea is important in reducing your uh, symptoms. And believe you me, that we usually offer every patient with in pregnancy to have this ginger tea to relieve their symptoms, but practically it won't work. And even in the guidelines, they told you that if you are going to say that, it might have reduced your scores. Like, but if this thing is, if you are as a GP, if you are telling her to take the ginger tea, then the chances that the patient will not rely on you because she will say that this doctor is not of worth and she is telling me about the ginger tea, which is not even in some cases the symptoms can aggravate as well. So there is no role of ginger tea. So then there says discussion about the problems of the medication. Here, why metoclopramide is second line due to the extrapyramidal symptoms. Why extrapyramidal symptom is occurring, then how to minimize. These are the dystonic reactions which are present with this, and we have to minimize by the slow infusion. Okay, at least over 3 minutes with the help of pump. Then comes the woman should be asked about the previous adverse reactions. We have discussed this in this previously. Then comes the other additional medications that should be given. So, and what are the safety profiles? So, first line, why it is called first line? Because it is safe. So, it is safe to take in the first half of the pregnancy. In the second line, we all know that ondansetron can cause the midline orificial defects, and it should not be taken. But we have discussed about it that this thing now Nahra did not like warn us now, and we can use it safely. And even at the end of the guideline, they have given you one chart in which they have told you that how common the problem is present with ondansetron. Data has confirmed that corticosteroid use in the first trimester is not associated with increased risk of congenital malformations. So now they are telling us about the safety of these products, these medications we are using. So overall and specifically, no increase in the orifice affecting cardiac defects or hypospadias following the first trimester use of corticosteroids. So what adverse effects can occur from nausea and vomiting and how they can be prevented? So we all know that these we have to have a look on urea and electrolytes, especially in those patients where we are going to give intravenous fluids. Then histamine like type 2 receptor blockers, like in the form of proton pump inhibitors, they should be given to the patient for the GERD or for hepatitis or for gastritis. So, it is usually recommended for the recurrent intractable vomiting and for gastroesophageal reflux disease. Thiamine supplementation, it minimizes the effect of IV fluid. We are giving more like in the form of dextrose. So, thiamine, if it is given, it can reduce the risk of Wernicke encephalopathy. Thiamine supplementation is very important, either oral, 100 milligrams CDS or intravenous as a part of the B-complex Fibrinix should be given to all the women admitted with the vomiting and it is with a severely reduced dietary intake, and especially for those patients who we are going to give the dextrose in the parenteral nutrition. So ideal nutrition is 0.9% saline with added potassium chloride. So when all other medical therapies have failed insufficiently managed, so this is the last resort that we can do the parenteral treatment. So for parenteral treatment, we have to do the multidisciplinary routine. We have to involve the gastroenterologist and we have to continue the ongoing management. Around 10% of the women with hyperemesis gravidorum will terminate unwanted pregnancy and due to this condition, a self-reported risk is 89%. So this is the termination, and it is not usually advised, and it is advised just in those cases where the the treatment is not effective and refractive vomiting is there. So now I'm going towards the charts which are present at the end of this presentation. Let us discuss those charts. So before going for termination, we have to assess the mental condition of the patient as well, because those who are poorly tolerated, they can have more chance of postpartum depression, even PTSD, and the mental health is very important. So if anything is not working, we have to do the improvement. I will provide you this highlighted guidelines. So you can study from here as well. I am just narrating to the important points from this guideline. We have to make the multidisciplinary team approach. We have to involve the psychiatrist. We have to involve the dietitian to make a look on nutrition. And then if we are going to provide the parental nutrition, then proper referral to the multidisciplinary team is important. So this is all about that. So all therapeutic measures should have been offered before considering the termination of pregnancy. So only 10% will require that. This is important thing. Okay. What are the long-term effects of nausea and vomiting? There are no evidence of significant effects. Okay. What are the long-term effects? Mild to moderate has no effect, but the severe can have anxiety or so small increased risk of certain adverse outcomes in the infant born to women who are having hyperemesis gravidorum. With babies can have the anxiety disorder. Baby can have ADHD and autism, which is important. For future pregnancy, we all know that they are at increased risk for recurrence. So now when we're going to start with the chart, I think I've already explained two charts, which are the tools, which tools which are used to diagnose the quantify the problem. I'm clear so far. Anything you want to ask so far? Any questions till now? Okay, this was the first chart, which is the pregnancy unique. quantification of analysis you take, and I have explained you everything. Like how you are scoring for mild it is 6, for moderate it is 7 to 12, and for severe it is 13 to 15. And here is the health score. And now these are the therapies which are we have discussed already. First line, second line, and third line. Take a print out of this paper and place in front of your eyes, either on of your wall, so that you can look on into it and you can memorize the doses. So this is the visual risk summary. So among so much babies, only this baby, this dark purple baby will be affected with the oral facial defect. If we are going to start with the ondenseron. So the risk is 11 per 10,000, which is very rare. So if the patient is not affected, then the risk is 11 per 10,000, and if the patient is exposed to ondenseron, the risk is 14 per 10,000. And this is also an important exam question as well. So always look at the end of the guideline. You have a lot of things that can be given, that can be asked from the guideline. So now they have given you the summary for the general practitioners. For the general practitioners, why is the active management of nausea and vomiting in pregnancy is important? They should know the importance and how the pharmacological treatment should be started. They should identify the risk factors, the onset of symptoms, and what are the prior history, and what has been done with the midwife so far. So we all know that prior to representation towards the GP, they have their midwife, and this midwife is scoring their symptoms in the charts. So what are the practical points? Some other validated patient symptoms that should be like asked. Then comes the antihistamines, which are the phenothiazines, and we all know that doxylamine it should be prescribed by the GP. And in the severe cases, severe diseases, multiple antibiotics can be can be given together. Ketonuria it should not be used as an indicator for dehydration, and secondary care guidelines should be given that when the patient should be referred for inpatient management. Okay, and the full mental and physical assessment should be there. Yes. So here is the initial assessment now. The patient has been initially assessed, and now the severity has been diagnosed, and it has been scored by the PUK. Like the score is scores that the score is between 3 to 12. The score is 10 out of 15, and this is the way to the patient. So what will the management here? Management in the community. Now the GP is managing this patient. So you have to memorize these three steps. Okay. This is the ambulatory management. This is the management in the community. If the patient is on antibiotic therapy, we have to reassure about the recommendations. We have to support. We have to encourage our hydration. We have to offer the dietary advice. So she should eat little, and she should have to prevent an empty stomach. Okay. Consider the use of laxatives. We have to give the proton pump inhibitors like the patient who are like H2 receptor blockers, and then comes the mental health assessment. So once the patient is like been assessed, now we have to call her after 24 hours because it is for validity is for 24 hours. Patient is reassessed in 24 to 72 hours, and now she is improving. She will be back into the community. There is no need to refer her to other services. But there is minimal or no improvement, then we have to start one either the second or third antibiotic, as you can see. So it is called up titrating. So we have to do when up titrating, we have to add drugs as opposed to replacing them. Many women may require more than one antibiotic, and so we have to refer for the inpatient management if the red flag signs are there. So what are the red flag signs? We have to know that. We have to memorize these red flag signs. Wait a minute. horrifying to me. I guess yes, these are the red flag signs. Any future score with any complication like severe dehydration or UTI, inability to tolerate oral fluids, unresponsive to outpatient treatment, clinical dehydration, weight loss, confirmed or suspected comorbidities like diabetes or UTI, comorbidity and unable to take medications in these conditions, and concerned mental health. So these are the red flag signs. So if the patient is not improving and develop any red flag signs, then we will refer to her for inpatient. But if there is no such red flag signs or any QK score, here you can see QK score of more than 30, 13. Here the score is 3 to 12. So this is the question. This side of the guideline is question, and this is one question, and this is one question. And now you will go and solve the question, and you will find it very easy. So here the score is more than 13, but there are no complications, and patient is unable to tolerate the oral medications. And now we are giving her the ambulatory services. And what are the ambulatory services? I have already explained you. And if any red flag sign, any PUK score, if the score is 3, but the complication is there, you have to refer for the inpatient management. Okay. Now comes the management of nausea and vomiting in general practice. This is the checklist that is being provided to the midwife, and here she will do this tick in the box, and she will assess, and this will help the GP to identify the problem. And here you can see the whole details of observations have been given, the whole signs of dehydration methods. This is the checklist that has been provided to the GP so that they can certify the patient. So here you can see the urine dipstick, the urea electrolyte, and food blood count and blood glucose. These are the initial testing. Then comes the diagnosis, and the future score is already given here. So here they will take the diagnosis whether the patient is going towards the hyperemesis gravidorum or not. And here comes the management again. We have to do the community medicine, community care, and then the ambulatory care, and then the inpatient care. So these are the antiemetics. So antiemetics, I have explained to you that how you are going to provide antiemetics. Up titration is very important. Okay. So initially select one line. First line antiemetics. Use the combination of drugs in the women who do not respond to a single antiemetic. So women are titrating add drugs as opposed to replacing them. Different classes of drugs may have synergetic effects. So we can try first with the second or first with the third even. So and some women will require the combination even 3 plus antiemetics to the control of symptoms. And for all patients, you have to consider histamine type 2 receptors, receptor blockers, then thiamine supplementation, laxatives, and venous thrombolytic risk assessment. Okay, VTE risk assessment should be done for all the patients. And then comes the postpartum planning and the future pregnancy and signposting. And patients with severe hyperemesis gravidorum are at the risk of post-traumatic stress disorder. And for that, it is required we have to refer them to the appropriate services. Okay, these are one, two, three, and four. These are the four services, which is the pregnancy sickness code, Heart Foundation, UK Terrology Information Services, and best use of medicine in pregnancy. So these are the services that have been used for the referral for these patients. Okay. In the future pregnancy, early use of lifestyle modification should be restrained. Preemptive use of doxylamine and pyridoxine can be used to reduce the severity of disease in subsequent pregnancy. So you can, if the patient is not responding to 10 by 10 dose, you can increase up to 20 by 20 dose. Now, the management of nausea and vomiting and hyperemesis in the ambulatory care. Now, you can see the difference. In the previous chart, you can find a difference here. We have four tests in the previous chart. The community care, urine dipstick, urine electrolyte, food blood count, blood glucose. Here, these are the two initial tests. Additional tests are being like patient will be tested for amylase and for venous blood gases as well. And detailed examination should be there. Here we have to assess the mental status as well, and we have to tick all these boxes. And here you can see the possible drug cause, infectious symptoms. So for the ambulatory, this is the chart, and this is a tick chart which is used for ambulatory care. So once the patient is been referred for the ambulatory care, we have to do these checklists, and we have to perform these all tests. So this is an important. All every point of the guideline is like when given in the last few charts. So don't forget to take the printouts of these charts and to memorize these charts by heart. Again, you have to quantify the symptom by QT scoring, and here you can see for ambulatory one, QT scoring 3 to 12, but no red sign, no red flag signs. We have given the IV fluids, and now we are going to decide the patient. We have to do the uptitrating and anti-emetic therapy. Tick the box. We have explained the oral hydration. Tick the box. If she is able to maintain the oral hydration, or if she is if she is having no mental disorder, if she is not having epilepsy, and she can take her oral hydration very well at home, and she is very well educated, then you can tick this box. Offer the dietary advice, and we have to refer for the perinatal health services wherever required. Now we have to start this patient from here. And the score is 3 to 12, and there are no red flag signs. But if the score is more than 13, there is no complication. Patient is not able to tolerate oral intake, and now we are sending her for ambulatory services. We have to take IV9. We have to take the relevant blood test. I have explained earlier. We have to give her the ideal solution, which is 0.9% saline with 20 millimole of KCl. Then thiamine supplementation, which is either in the form of Febrinix, which will this vial will be entered into the fluid that is being given to her. And now we have to stratify this patient from here. This center point is important. We have to reassess this patient. If the patient is improved from this therapy worked on her, patient is improved, we will go and discard this patient here. But if this patient is reassessed and any future COVID complication, again, we have to check all these tests, and here we have to go with the inpatient management plus refer to these services as well. So these services they will come up and they will take care of this patient, and the admission of this patient will be decided. And again, we have to provide them histamine blocker, thiamine supplementation, laxatives, and venous thromboembolism risk assessment. Then comes the emergency department management. Here you can see this is a checklist. The patient, this is the checklist that is being referred from the GP. Uh, check everything from here, ask the history, see the signs and symptoms, initial recordings, and then neurological signs are seen. Then during this stage, during electrolytes, everything is been done. Mm. And then you can see here, mental status is given in the separate box. So mental status is important. Then future system is been used, and here again, the patient either will be retained in the ambulatory, then or it will be referred to the inpatient treatment. Okay, so this is the inpatient management here. Now, in the inpatient management, so this is inpatient management. Okay, so now they can even ask you an extended match person. Then in the inpatient patient has been given in the intramuscular IV antiemetic. What next step will you do? The next step is the provision of fluids, and this fluid should contain potassium chloride along with the daily monitoring of electrolytes. Then we have to prescribe her thiamine supplementation, Then we have to do the venous thromboembolism prophylaxis, and you have to tell me the score, okay? All of you, you have to tell me the score. Then prescribe the histamine receptor antagonist. Then mental health assessment plus refer to the mental health services. Then schedule. So these are the points when we have taken the patient as an admitted patient. So this is the assessment. This is all the assessment. You have to memorize all these things. Then comes the ultrasound. Then comes the constipation treatment as a form, in the form of laxatives and either anterior or parenteral therapies if the symptoms fail. If the patient is improved and if the patient is discharged, here you can see we have to do the up titrated antibiotic. So whatever she is taking, if she is on first line, we have to start first line with along with the second line, okay? Or we have to increase the dose of first line. So up titrated antibiotic therapy means that either we are increasing the dose of first, or we are giving an additional from the second line, or we can combining the all three drugs, offer the dietary management, and then have to provide the contact numbers for the early pregnancy unit. That if they have any problem, they can have a contact in the early pregnancy unit. Okay, so up titration first line, then not with more, then add the second line, and when up titrating, add drugs as opposed to the replacing them. Then always in the post, always assess the patient for the postpartum and for the future pregnancy, that these patients are at risk of developing post-traumatic stress disorder, especially those who are having hyperemesis gravidorum. So lifestyle modification should be advised to them, and early referral to the perinatal maternal health system should be provided to them. Okay, so these are all the charts. These are screenshot of the chart, and this is the most appropriate IV hydration. Onset, ondansetron available in Pakistan. The dose is 8 milligrams. Then cinnarizine tablet. So these are the charts we have already discussed, and I have added in the presentation. You can take a screenshot of, you can take a printout of these charts, and um, you have to memorize these charts. So everything that has been given in the guideline is summarized, and the management is given in the end of that. So hydrocortisone, prednisolone, ginger tea should not be given, and it may um, also delay the access to the effective treatment. Thank you so much. Um, I hope my lecture is concise and will help you in solving the questions related to this guideline. This guideline has been recently updated, and I have provided you every possible detail that has been given in this guideline. Thank you so much, and now I will open the house for the questions. All kind of questions will be accepted. So, any questions so far? Any questions? Hope everything is fine and your preparation is going smooth. If you find any difficulty, you should not forget to ask me, and wish you very good luck for your preparation and good luck for your exam. If any query, you are most welcome to ask. This means that topic is explained very well. Okay. So thank you so much. Thank you all of you. Good evening and take care. Allah Hafiz.